Hey everyone, we're going to go ahead and get started. So I just want to welcome you today. My name is Luke Hansen, and I'm a program manager with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. And it's my pleasure today to welcome you to our webinar, Basics of Sterilization, Disinfection, and Sanitization in Schools and Healthcare Settings, featuring Dr. Ziad Kazzi from Emory University. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC IPC, and is co-sponsored by the Deep South Center for Occupational Health and Safety. All right, so a quick note about the ARC IPC. It was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to protect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, and view infection prevention and control resources at our website, go.uab.edu/ARCIPC. And you can also email arcipc@uab.edu with any questions and to stay up to date for future trainings. You can also sign up for our newsletter on the homepage of our website. We'd like to take a quick second to thank our co-sponsor today, the Deep South Center for Occupational Health and Safety. They have an upcoming event, Audiometric Testing and Hearing Conservation Program, that'll go the week of December 13 to 17. And you can learn more about that program and the center as a whole at their website at sites.uab.edu/DSC. Really quickly, want to invite you to join us for our next webinar, also with Dr. Kazzi, and that'll be on January 18th, also at noon. That's going to be the appropriate use of disinfectants in schools and healthcare settings. And in this webinar, Dr. Kazzi will discuss the potential health hazards from inappropriate use of the commonly used disinfectants, quaternary ammonium compounds, hydrogen peroxide, and phenol. That webinar will also be presented by the ARC IPC and co-sponsored by the Deep South Center, and it's approved by the Alabama Board of Nursing for 1 CEU contact hour. So again, that'll be on January 18th at noon Central Time, and you can register at the link on the slide or on our website. Also, continuing ed credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. To receive credit, you need to register for the training, watch the entire program, and complete the evaluation upon completion. Upon completion of the evaluation, you'll be redirected to the Alabama Nursing CEU request form, which you'll also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety, and you don't have to submit directly to the AL Board of Nursing since the Deep South Center will take care of that. CE units for this program will expire on November 16 of next year. If you do experience any issues, then please just email our address. Again, that's arcipc@uab.edu. And we'll also put that email in the chat box for the duration of the presentation. And finally, it is my pleasure to introduce our speaker today, Dr. Ziad Kazzi. Dr. Kazzi trained in emergency medicine at Emory University in Atlanta before completing a subspecialty fellowship in medical toxicology at Emory and the Centers for Disease Control and Prevention in Atlanta. From 2005 to 2008, Dr. Kazzi joined the Department of Emergency Medicine at the University of Alabama at Birmingham, where he served as a medical toxicologist for the Regional Poison Control Center in Birmingham and the Alabama Poison Information Center. During his time in Alabama, he participated in numerous training activities like the Explosion and Blast Injuries course. He is currently a professor at the Department of Emergency Medicine and the director of the International Toxicology Fellowship Program at Emory University. He's also the assistant medical director of the Georgia Poison Center and a guest researcher at the CDC National Center of Environmental Health. He's also the secretary treasurer of the American College of Medical Toxicology. As an emergency physician and toxicologist, Dr. Kazzi specializes in the recognition, triage, and management of poisonings and holds a deep interest in the areas of emergency preparedness, public health, and hazmat incident medical management. So without further ado, I'm going to turn the share screen over to Dr. Kazzi and let him run the show.
Welcome, everyone. Thanks again for tuning in to our webinar today. I know we're all bombarded with webinars every day, and this is just another webinar, but I promise you that in the next 44 some slides, you will learn some valuable information that will affect your day-to-day dealings with SARS-CoV-2 and these chemicals that we are using everywhere around our workspace, our home space as well. As Luke has mentioned, this is one of two webinars that you will be able to view The one that's on January 18th is going to focus on a few chemicals, quaternary ammonium compounds, hydrogen peroxide, and phenol. I also want to discuss hand sanitizers during that webinar. Today, we are going to look at the picture from a general perspective and talk about bleach. So this is how we decided to divide up the topics within these two webinar series. And of course, you will be able to access some podcasts that we are preparing as well, part of the ARC IPC activity. So why is this topic important to you and why you're spending your time today listening to me? Well, I guess because the COVID-19 pandemic has really created an unprecedented need for chemicals to disinfect our devices, our workspaces and homes, as well as to sanitize our hands. As a medical toxicologist, dealing with these chemicals is not something that is new for me, but certainly I've had to deal with them much more since the beginning of this pandemic. And this is because human toxic exposures to these chemicals, not surprisingly, have increased, not only in the US, but also worldwide. And I will address some of these issues with you today and also during the next webinar. This has been shown even at our level of poison center data. Poison centers that receive calls from the public or from other healthcare providers about chemical exposures record this data and analyze it, and have noted a significant increase in the period after the COVID-19 pandemic started in the exposures to cleaners and disinfectants. So this is really a reflection of what we really experienced at a personal level when we were really dealing with the initial arrival of this pandemic to the US, and now as we learn to live with it. So what I want to do today is really just set the stage and focus on disinfection as opposed to sterilization. But I want to make sure that we understand the difference between the two. I also want to discuss the important principles of proper use of these disinfectants. Proper use meaning for them to be effective, but also for them to be safe for us users and people that occupy the spaces we are disinfecting. When we do that, we will have to discuss some potential toxicities from these disinfectants, and we will feature today in this webinar the commonly used disinfectant, sodium hypochlorite, also known as bleach. Now, disinfectants are only one piece of this. Of course, when we started to deal with the pandemic, we had multiple questions, multiple tools at our disposal. Some of them persisted in their use, others kind of died down. But essentially, we were thinking about this virus in terms of droplets, in terms of aerosols and fomites. And to try to protect ourselves, we had different strategies. For example, decreasing the viral count that we could get infected from. How do we do that? Well, we can ventilate the space we're in. We can use air filtration. We can also inactivate the virus itself. This is where disinfectants come in. There are also other ways to kill the virus, such as ultraviolet light. What do we do to protect ourselves? Using PPE with respirators and masks, gloves and protective clothing. And I also want to remind you about the hierarchy of protecting ourselves in our workspace. The PPE is just a piece of this. And of course, there are other steps and tools in this process, including eliminating the virus, substitution of our work habits or work procedures to avoid being exposed to the virus, what engineering controls we can implement to the ventilation system, for example, to decrease the viral count, what administrative processes we can follow in terms of our staffing, in terms of our patient flow or student flow in the school that can help us. PPE is just a small piece of this. And again, disinfectants also are a small piece of this. And really the best successful strategy is a combination of all of the above. That said, our understanding of the virus has evolved during this pandemic. Initially, it was thought to be a combination of droplets as well as fomites. This is why initially we thought that you basically have to stay 1 meter away from another person because this droplet is large enough to fall within a meter to the ground, fall to the ground in under 5 seconds, and cannot be therefore necessarily inhaled in an effective manner unless you're really close. And this is because we thought that the viral particle was larger in size. We thought it would be greater than 100 micrometer and therefore heavy enough to fall down rapidly. Of course, once it falls down, it becomes a fomite. And at that point, we can also potentially get exposed to it by rubbing our hand to the fomite or to the surface where the fomite is laying, and then touching our mucous membranes or placing our hand in our mouth or on our face and our eyes, and therefore getting infected in that manner. As we have learned more and more about the mode of transmission using epidemiological data, as well as lab data and experimental studies, we've realized that aerosols are to be really emphasized again, because we've discovered that the viral particle size can vary. And we have sizes that are less than 5 micrometers and also sizes between 5 and 100 micrometers. Those sizes will allow the virus to travel larger distance in air and to float around for hours. This is why now we believe that aerosol transmission is an important, more important than we thought initially, mode of transmission. So this is why now we're emphasizing a bit more the respiratory protection. The fomites are still a potential concern, and this is why we are still using the disinfectants, because that's part of the whole protective scheme that we follow. But I want to invite you to consider aerosol transmission as you plan at your schools, at your hospitals, at your workplaces, or your childcare settings, and consider how you can modify your risk from aerosol transmission. And I want to just point out that recently, part of the American College of Medical Toxicology that I belong to, and I am the co-moderator of our COVID-19 webinar series, we have a mini webinar series that is funded by the Pediatric Environmental Health Specialty Units and the American Academy of Pediatrics, which looks at the safe disinfectant use. And under that webinar mini series, I want to point your attention to a recent webinar that we hosted on November 3rd, 2021, with Dr. Marwa Zatari, that focused on this topic of aerosol transmission and mitigation using ventilation. Of course, this is outside the scope of this webinar, but if you want to view that webinar, it's available for you at the link above. We will make those slides available to you in the form of a handout. Going back to disinfectants, and again, I'm not personally an infection control specialist, I'm a medical toxicologist, but I've learned a lot over the last year and a half about viral transmission and also infection control. And what I've learned is the importance of the Earle Spaulding classification, which basically tells us that when we decide on the level of disinfection needed, we have to consider a couple of elements. One of them is the object's intended use. So if you're disinfecting an object, you have to ask yourself, what is this object intended for? If the object is intended to be used in an area that is sterile, inside of a blood vessel, inside of an area that is in the vasculature, think of a heart valve, or think about a catheter that enters inside the artery, like an angiographic catheter, then in that case, you have to be very cautious about any microorganism or any microbe that could be growing on the instrument. And this includes spores that could be growing in large numbers and are resistant to deactivation. In this case, in a critical device use situation, you want to pursue sterilization. Now, when the device itself is intended to come into contact with mucous membranes or come into contact with non-intact skin, then in that case, you still have to consider some of the spores that can be growing there. And you have to use a technique that will deactivate spores, except if they're in very large numbers. And in this case, what you do is you pursue a high-level disinfection. Last but not least, and what we most commonly encounter at a hospital, at a school, at a childcare setting, at a workplace, is non-critical devices that really come into contact with intact skin by touching it or holding it or using it. Think about a stethoscope, think about a computer keyboard, a table, etc. And for these, we really need to worry about low-level disinfection, because we're not really concerned here about the effect of spores on the body and other types of microbes. And we're really going to be satisfied with low-level disinfection. And this is one of the things that you do when you consider what procedure to follow. The other element that I mentioned you need to consider is the type of microbe you're dealing with. And in this case, SARS-CoV-2, luckily for us, is not a very difficult organism to destroy. And therefore, in the hierarchy of microbes that we need to address, of course, spores are the most resistant. And those are the ones that require the sterilization, especially when they're in large numbers. Of course, sterilization takes care of spores, but mycobacteria, non-enveloped virus such as norovirus, fungi, bacteria, and envelope virus, where SARS-CoV-2 lies, an envelope virus that is the most vulnerable of the listed microbes on the slide. Now, sterilization is a whole different process that is outside the scope of the ARC IPC, as well as outside the scope of our presentation today. And here you are using some chemicals like ethylene oxide, you are using steam, you are using hydrogen peroxide gas plasma, ozone and hydrogen peroxide together, and vaporized hydrogen peroxide. And these, of course, are important for us and used on a daily basis at hospitals around the United States. Some devices can tolerate the application of steam, others cannot resist steam, therefore they require ethylene oxide. And ethylene oxide, of course, is a different whole chemical that we're not going to address in this webinar, but has its own specific toxicological effects. And like I said, when we are able to tolerate a small number of spores that we can destroy with the chemical, and we have a small number of spores on the device, then in that case, we can follow high-level disinfection, because high-level disinfection will take care of whatever the sterilizing took care of, except if you have a large number of spores. And this, of course, includes SARS-CoV-2. And high-level disinfectants are numerous. We have many options, but we always have to remember that those have to be applied for a specific duration at a specific temperature and at a specific concentration. So not every chemical is the same, and therefore paying attention to what chemical concentration we need and how long we should apply it for and at what temperature. And these are some examples of chemicals that can be used as high-level disinfectants. You may see some of these chemicals later on in the low-level disinfectants, and you may get confused. Why did I list them in both categories? Remember, what matters here is the concentration, as well as the application method, sometimes the combination of chemicals that are used in the process. What we are going to focus on today is what we need in our day-to-day procedures, and therefore really dealing with SARS-CoV-2. And luckily for us, low-level disinfection is able to handle bacteria as well as envelope virus like SARS-CoV-2. And this is what we are going to focus on in this webinar series. Examples of low-level disinfectants include bleach, which we will discuss today, but there are other compounds as well, like the quaternary ammonium compounds that we will discuss in the next webinar. We will discuss phenol, we see it listed here. We will also discuss hydrogen peroxide, which is also a low-level disinfectant in low concentrate when it's used in low concentrations, and then discuss some of their toxicities. Now, when you at your workplace are looking to buy or to use a disinfectant, you want to make sure that basically it works against SARS-CoV-2, and I just told you, just discussed how you do that. You want it to be rapid because you want the effect to be quick, and you want it to be able to remain wet a little bit so that it actually is not going to evaporate before the time required to inactivate the microbe. You also want it to be resistant to environmental factors, especially if there's organic matter like dirt on the surface. How is it going to react to dirt? Is it going to be able to penetrate through dirt and reach the virus? You want to make sure it's safe for the applicator and people that occupy the room that is going to be used afterwards. You want to be easy to use with an acceptable odor and a reasonable cost. And if you go just to any supermarket, you will see the variety of prices for these products. A soluble product is useful and stable in concentrate and dilute solutions. You want to be able to clean ideally. Sometimes if you have dirt, some of these chemicals can clean as well. Non-flammable for safety. Non-corrosive to be able to be used over instruments or metallic surfaces. And to have just enough persistence to inactivate the microbe. Of course, there are also environmental considerations. You want it to be safe for the environment. And you want it to be also safe for the user, not only acutely, but also in the long-term consequences of use to the person, as well as potentially if the person is pregnant, to the fetus. Now, the Pediatric Environmental Health Specialty Unit has produced a lot of free resources that you can access on their website related to this. I'm just posting one of them here that really emphasizes the importance of following specific steps when disinfecting a device or surface. One thing that we tend to forget, and I know myself, I forget to do that, is cleaning the surface before you apply the disinfectant. You don't want the surface to be there dirty because the dirt can stop the penetration of the chemical. It can also react with the chemical and produce toxic byproducts. So we tend to forget to do that. Also, we tend to forget to try and optimize the ventilation of the space we're in. I understand some spaces do not have windows or easy ventilation, or the weather outside is too cold or too hot, but keeping that into consideration is important. Using gloves and goggles or protective eyewear, especially when we're dealing with concentrated solutions for the goggles where the splash may be dangerous to the eyes. Gloves, of course, these disinfectants are not meant to be placed on living tissue like skin, for example. They are meant to be used on surfaces. Therefore, disinfectants are different than antiseptics. Now, antiseptics, those can be used on living tissue. But what we are looking at today is disinfectants that should not be applied directly to the skin. And please, please, please follow the label instructions, because of the large number of chemicals. These instructions are variable and must be followed, because one practice that you have with one chemical product is not going to be potentially applicable for the next product you pick up off the shelf. Now, the Environmental Protection Agency has done a lot of work in this pandemic, as well as the United States Food and Drug Administration. They had to deal with an increased demand for these chemicals. They had to deal with chemicals that are imported from outside the US. They also had to deal with concern by the public, in addition to dealing with environmental concerns. The EPA had already developed a list of chemicals that are safe or relatively safe to the user and also good for the environment, or safe or gentle on the environment. And this is called the EPA Design for Environment Antimicrobial Program. And this website lists your disinfectant products that are both safe for human health and the environment. And if you look through this DFE list, you'll find those that are classified as less toxic, like citric acid, dilute hydrogen peroxide, L-lactic acid, and ethanol. And you can find some that are listed as more toxic, like bleach, chlorine bleach, quaternary ammonium compound, and others. The EPA has also provided us with a very useful list of the called the List N for disinfectants that are effective against SARS-CoV-2. Now, this List N is something that I will teach you how to use, but I want to show you first a snapshot of the website for the DFE certified disinfectants. And you can basically look it up on this website and figure out which one would be safe for the user and the environment. The EPA has also provided a number of resources that you can use and download and post in your setting, in your work setting or school setting, that could be a reference for people using these chemicals, such as, again, following the guidelines of the CDC, state and local public health, cleaning the surface with soap and water first, using EPA registered disinfectants according to the instructions. Be careful with people that have asthma when you use this. Be careful spraying these chemicals. Be careful fogging them. Some of these chemicals are better used applied to a rag and then cleaning the surface that way, as opposed to spraying them everywhere. I know my wife, for example, at home, I often find her spraying the chemical from far onto a table. Now that can really cause a mist of chemicals that can expose us. It can also lead to an inappropriate application on the surface, or an incomplete application on the surface, which decreases the efficacy of disinfectant. Of course, some people are using UV lights and ozone generators. Those have their own hazards. You can find one of our ACMT webinars on that topic as well. And again, don't ask children or students to apply these, because they may not know how to apply them safely, and they may not have gloves to use when they do that. And again, remember to follow the label directions and try to be careful what you're purchasing, so that you don't end up buying something that's unregistered. Because of the increased demand, we may have found some new products coming in that may or may not be completely registered or properly registered with the EPA. Now, the end list of disinfectants that I mentioned to you is valuable to us, because it basically will tell you if the chemical you are using, the product you are using, is active against COVID-19 or SARS-CoV-2. And they do that by either testing it against SARS-CoV-2 or knowing that it works against a microorganism that's more resistant than SARS-CoV-2. And the way to do this is you have to look at the EPA registration number, and you have to use those first two parts of the EPA registration number. If you look at the right side here of the slide, let me show get my pointer going here. You see here, these are EPA numbers. You use those first two parts to enter them in the EnList data search tool. And then you will find out if it is going to be active against SARS-CoV-2. This last number here, you don't need to include that. That actually differentiates different products that use the same chemical. And here's an example for hypochlorite, for example. If you enter hypochlorite, which is the topic today, you'll find there are 75 products that contain sodium hypochlorite. This is why it can get confusing. If you enter that website, you'll find the different products here. You'll find their EPA registration number. Look at these two products here. They're both sodium hypochlorite. They're both made by a specific company, but they're both two different subproducts. And you see how they both have different end number here in the EPA label, but they do have the first number the same. And you can see what it tells you about it. The company, the directions, the contact time is important. How many minutes you need to apply it before it inactivate the virus, etc. So that's all I have regarding the general aspects of this webinar. Now I want to dive into bleach. Bleach is also known as sodium hypochlorite. Of course, it is called bleach because it can bleach material. This is why it was used initially as a bleaching agent for textile or papers, but it's also commonly used disinfectant. It's one of the most commonly used one in our childcare settings. Now, one thing to get through from the start is that there are variable concentrations of sodium hypochlorite. And the more concentrated it is, the potential hazard will increase. What we are talking about at school or at the childcare setting at home is on the lower end of the concentration, anywhere between 0.1% to 5%. And some people also dilute this bleach at the site of use, which is important to remember because you may be starting with more concentrated products, and then that could cause hazard to the person diluting if not following proper instructions, because the industrial use concentrations can be greater than 10%. The other thing to consider is that you pick up a product that is called bleach. Remember, this is sodium hypochlorite, supposedly. What else is in there? There are a lot of different formulations commercially made for different purposes, with a surfactant, a fragrance, with sodium chloride, sodium silicate, even sodium hydroxide, antioxidants, and anti-foaming agents. All of these are used to make them more practical for a specific indication at home or at the childcare setting or at school, but those can complicate the safety use of these products. Now, bleach per se, the sodium hypochlorite, is converted to hypochlorous acid. And this is what reacts with the amino acids, leading to the bacterial protein damage, and also eventually, in the same mechanism, damage to the virus, such as SARS-CoV-2. If you really dig in onto the mechanisms, you find that the mechanisms are more complicated than that simplistic way that I just described, and can be at the intracellular level, working on the proteins, etc., and oxidative stress that leads to the demise of the microbe. Bleach, again, should be used according to the instructions. What I just described in terms of safe use of the chemical applies to bleach. What's different about bleach? I am going to highlight that in the remaining part of this presentation. First of all, remember the dwell time, how long you need to apply it before it inactivates the virus. And for SARS-CoV-2, it can be a minute, it can be longer, depending on the product concentration. Of course, you have to remember that you have to clean the surface first so that you don't have a barrier to the penetration of bleach to contact the virus. There's concern with ventilation because bleach, depending on the temperature and the concentration, may have some presence in the respirable environment of the room if it's closed, for example, if it's a hot day, and therefore ventilating the area is important. When you are using these concentrated products, remember that you may get in trouble when you're mixing them together in a school, for example. Using a closed dilution system may improve your safety. And at the end of the day, you need to know what you're doing. If you're diluting that stuff in your own environment, you need to follow the appropriate steps to do that. Of course, when you're dealing with these concentrated solutions, you must wear eye protective gear. Gloves are always a good idea when they're using bleach because, again, it's not supposed to be applied on the skin directly. And most importantly, and I can't emphasize this enough, because I see a lot of people mistakenly drinking bleach placed in a bottle that looks like a water bottle or a soda bottle or a cup. Don't do it that way. Leave it in its own container. Don't transfer it to another container, because kids, elderly, even young people with good vision and good dexterity may make a mistake. And lock it up away from children. One thing that's interesting about sodium hypochlorite is its potential reaction with other organic material. So if you have organic material on the surface and you did not clean the surface and you applied the bleach, it may react with it and release some volatile organic compounds that have their own toxicity profile. And that's a whole different ballgame here, because now you're generating chloroform or carbon tetrachloride, which are much more toxic than sodium hypochlorite per se. Even, heating the bleach in laundry machines, which we do on a regular basis, can lead to an increase of production of chloroform. Now, once in a while, you may have an accidental ingestion or even an intentional ingestion. Now, those are a different story as well. And this is what really I see on a regular basis in my practice. People that swallow bleach, adults or children, usually are okay, especially children that tend to drink a small amount. So less than 50 milliliters is not a major problem, especially if it's a household bleach, not an industrial strength bleach. And those are a different story, because those can cause gastric burns to the esophagus and the stomach. Of course, these patients will present with abdominal pain, nausea, vomiting, diarrhea, and usually are well tolerated unless, again, suicidal large ingestions or ingestions of concentrated products. Occasionally, I see patients that are splashed in their eye with bleach, accidentally or intentionally, and that can also irritate the eye. They come in with eye burning, tearing, decreased vision, blurry vision, and of course, they need to be assessed properly. You see here how you have to basically assess the conjunctiva. You have to assess the cornea using fluorescein staining under a slit lamp for any abrasions. Should also, again, of course, irrigate the eye. What I usually do is I apply a local anesthetic, like tetracaine, then I insert the Morgan's lens and irrigate copiously with saline. And I continue to do that until I normalize the pH inside the eye's fornix. Another unique thing to bleach is mixing it. Where I come from, originally from Lebanon, we think that mixing two chemicals is better than one chemical being used separately. We think it's stronger. And we often mix chemicals together. And with sodium hypochlorite or bleach, that's a problem. Because if you tend to mix it with, if you end up mixing it with ammonia, for example, you can generate a gas called chloramine gas. If you mix sodium hypochlorite with an acid, you can release chlorine gas. And both chloramine and chlorine are strong irritants of the upper airway and the lower airway, and can cause significant airway issues as well as pneumonitis that can lead to respiratory failure. And I don't need to remind us here in Alabama or in the state of Georgia of the chlorine release during the Graniteville train derailment. This is a serious chemical reaction that we must avoid. So please do not mix chemicals together. This can be certainly a significant problem, especially when you have exposure to a large dose of these chemicals. And you can see here what can happen to the lung after exposure to chloramine or chlorine gas. Now, we're done talking about these severe, large exposures or mixing of chemicals together. Let's talk about the day-to-day use in the last 15 minutes of this presentation. Let's talk about the effects of low-level repetitive exposure to sodium hypochlorite, which is what you and me are exposed to every day. Well, we have to think about the skin, the respiratory tract, and some of the long-term effects. For the skin, like I said, we should not be applying this directly to the skin. But if we are applying it to the skin, remember our skin, all of our skins these days are dried up because we are using a lot of alcohol-based hand sanitizers and we washing our hands all the time. So we already have issues with our hands. They are dried up and they have already some sort of irritant dermatitis. And bleach is only going to exacerbate the existing irritant contact dermatitis. And it's going to be worse on people with pre-existing atopic dermatitis or eczema. Look at your hands right now and see if you find any of these lesions on your hand. These are lesions that happen from frequent hand washing, frequent application of sanitizers, in addition to chemicals. You can find here in the white asterisks several ill-defined, dry, erythematous, scaly patches on the dorsum of the hands and finger webs. Some of these become thickened. Look at these dark lesions that you see here, as well as scaling, fissuring. This is all, again, in patients that are applying frequently hand sanitizers or chemicals or hand washing without appropriate hydration creams on them. You can even see an allergic contact dermatitis. When you apply chemicals, you develop these itchy areas, erythematous areas that are scaly a little bit with small vesicles. Look at your hands and you'll see we all have developed some of these during this pandemic. And again, the importance here is to wear gloves when you're dealing with bleach and keeping your skin hydrated. The next topic is the respiratory tract. Now, this is a little bit controversial, so this is a little bit tricky to discuss, so bear with me just a little bit. Think about people that develop asthma during their occupation. This is called occupational asthma, which in itself is a complex diagnosis to make because you have two different types. You have an occupational asthma that is induced by a sensitizing chemical. There are some chemicals that you're exposed to them that induce an immune response that lead to the formation of immunoglobulin type E. These scenarios involve you being exposed to the chemical the first time, not having any symptoms, because it takes some time to develop an immune response. Now then when you're exposed to the chemical again, then you develop the symptoms of asthma. And if I expose you to this in the lab, bring that same chemical, I can reproduce these symptoms. That's sensitizer-induced occupational asthma. Now, what about the other type of occupational asthma? That's called irritant-induced asthma. Now, that one is not allergic. There's no IgE being formed. There's no immunoglobulin E being formed. This is a situation where you are symptomatic on first exposure. You develop bronchoconstriction on first exposure. Okay? And you can get it again and again every time you're exposed. And you cannot necessarily predict its occurrence in the lab, but it may recur again because it's irritant induced. So as you can tell here, one is more objective than the other. Both of them are challenging to diagnose, require careful history, careful occupational history, good documentation of the chemicals used, and assessment. And when you look at sodium hypochlorite or bleach, I'll start with the things that have been more supported with evidence. For example, yes, bleach can exacerbate people's symptoms, people that have existing asthma. So if you're an asthmatic and you're exposed to sodium hypochlorite, you can see exacerbations of asthma. And I've seen that in my ER. I've seen a couple of patients in the last year, they come in with an asthma attack. And then when I talk to them, they tell me, well, I've been okay for the last several years. I don't know what happened this last year. I've been having more attacks. And then I ask them, what do you do for a living? And they'll say, I started working as in environmental services at a hotel. Another person I saw told me she was working at a cafeteria. So that is an example of bleach exacerbating asthma, existing asthma. The more controversial topic, which may or may not, may or may not have enough evidence, depending on how you interpret the evidence, is whether exposure to sodium hypochlorite or bleach can cause asthma. If you look at the Association of Occupational Environmental Clinics database, bleach is listed as an asthma inducer and a sensitizer. But these studies to prove that are difficult to do because basically you have people that report using bleach and developing asthma. So the association is there, but is there causation? It depends on the study you look at and depending on the evidence. It's really hard to prove causation in these scenarios. This is complicated by studies that show the opposite, that show that bleach actually reduces indoor allergens like molds and dust mites, and therefore decrease the incidence of asthma. So, which we know, the dust and dust mites and mold can induce asthma potential. So again, this is a complex issue, but the bottom line, the management is the same as asthma with bronchodilators and steroids when needed, and again, avoiding the exposure. And when using this, using a mask, eye protection, ventilating the room, do not spray these if you can, because then you cause more respiratory exposure, and potentially look for alternative, safer agents. The last couple of topics I want to talk about are the long-term effects of cancer. And the good news is that sodium hypochlorite currently, according to the agency, the International Agency on Research for Research on Cancer, the IARC, is classified as not classifiable regarding its carcinogenicity to humans as a group 3. And why is that? Because you don't have human studies that show it's carcinogenic, and you have very limited animal studies. So that's good for us. The bad news is when you mix it up, when you apply it over organic material, like what discussed earlier, and you release carbon tetrachloride or chloroform, now those are group 2B, and those are possibly carcinogenic in humans. So this is why it's important not to apply it before cleaning the surface. Is it safe during pregnancy? Again, we don't have enough evidence to say it's unsafe in pregnant women. There's limited number of studies and no direct evidence of reproductive toxicity. There are some studies, for example, one study looking at pregnant women exposed to drinking water that contains sodium hypochlorite. In these women, there was no evidence for congenital malformations. There was some evidence of preterm birth, decreased body length, and head circumference. And this is listed here as a reference on this slide. So in summary, the safe use of disinfectants for SARS-CoV-2 relies on proper usage of these chemicals, proper selection, proper usage, and following the instructions provided on the label. Remember, clean the surface with soap and water before applying these chemicals. Use your mask, your gloves, and your protective eyewear. Ensure as best as you can proper ventilation of the space where it's being used. Remember that bleach can be problematic for asthmatics. It may or may not cause asthma, but it certainly irritates upper airway mucous membranes, including the eyes. Don't apply it to an intact skin, as it can cause irritation and irritant dermatitis. And luckily for us, we think it's relatively safe from the perspective of cancer and pregnant women. And I hope you've enjoyed this presentation. I hope you've learned something from it. And if you have any questions, please do not hesitate to email me or follow me on Twitter and send me a message on Twitter. I typically monitor both of these and will respond to you if you like. Thanks again, and I look forward to your questions.
I've got a few that I wrote down, just waiting for folks to come in. Specifically with SARS-CoV-2 or any new disease, any outbreak situation, what's the trial and error process like, in the sense of, bleach seems pretty standard in terms of it's relatively safe, it's relatively accessible, but just in learning new disinfectants, new disinfectant usage, I'm sure it's unique to each case, but could you walk through that a little bit?
So again, I think I understand your question. Are you asking about the process of approving disinfectants?
Yeah. So where I'm coming from, I remember specific to COVID, when things first started, it was a matter of, everybody was kind of in a rush to get hand sanitizer, to get bleach, to get cleaning supplies. We all thought, okay, if nothing else, we'll keep surfaces clean. And as things evolved, we learned more about aerosol transmission and things of that sort that kind of tweaked our approach to best practices on mitigating spread. But I'm just curious in general for outbreaks, especially when it relates to disinfection, what the process is like to determine the best routes to go. Is bleach kind of the number one, let's go ahead and use that, and then we'll look for other approaches? Or what's kind of some of the trial and error, the scientific process of learning the best ways and types of disinfectants to use?
Okay, that's good. Okay. So we already have a lot of knowledge regarding infection control, especially with these chemicals that are well known to our infection control specialists. What we have noticed in the past year and a half is the new technologies that are being developed, such as ways to produce hypochlorous acid, for example, in your own, using a specific new device, using of ultraviolet light to inactivate the virus in specific areas, using air filtration, HEPA filters, increasing our air exchange rates in a specific space, using a combination of measures, using a disinfectant plus a ventilation method. Using experimental studies. We've seen a lot of experimental studies now looking at SARS-CoV-2 specifically and seeing what the effect of these various chemicals on the actual virus, looking at the virus's persistence on a surface, whether it's plastic, wood, or paper, etc., and see how much time it requires to be inactivated by various chemicals. All of that has increased our knowledge during the pandemic and added to what we already knew before that. The good news is that of this pandemic is that we've really all raised our awareness about our environment. One of the major points of Dr. Marwa Zaatari's presentation on November 3rd was that one of the good things that came out of the pandemic, if there's anything good that came out of it, but if you are going to look at the silver lining, is that now we are more aware about our environment, our space that we live in, the ventilation, the cleanliness. You know, again, SARS-CoV-2 is not the first virus we're around. Think about RSVs, think about Clostridium difficile, think about influenza. And I think we're going to learn a lot of valuable lessons, hopefully after this pandemic is under control and we learn to live with this virus, which we know we may have to live with it like we live with the influenza viruses. At least we'll have a better understanding and better appreciation for the importance of ventilation, importance of cleaning our surfaces. Perhaps some people will never remove the mask when they're in public spaces. You know, I think all of these are lessons that will be potentially important for us as we move forward in our lives. And I know we all want to move forward in our lives. And I think we are better equipped today than we were, more than a year ago.
Just had a question come in here. No, that makes perfect sense. So what are your recommendations on the safe use of disinfectants if you're in a room that is not well ventilated? So for example, a bathroom or another interior room. And would you recommend using fans to circulate the air or something else?
Wow, that's an important question. You know, I don't claim to be an expert in ventilation. I want to make sure that this person, please look at the webinar on November 3rd. It was addressed specifically. But what I've learned from Dr. Zaatari is that you can actually make your own, even if you want to buy a filter or make your own filter. Using a fan, there'll be a fan involved in there, or like some sort of way to suck the air through a filter, and you can basically filter the air, clean the air, or purify the air of that room that you're in. Certainly, if the fan is going to be the problem with the fan is it may end up like aerosolizing more of these chemicals, so that you're basically inhaling them more. That's the one concern that I have. Even opening the window may not be effective. You know, I learned from Dr. Zaatari that even opening the window, how do you know that there's enough wind or that's going in to change the room, the air in the room? The key here is to try to circulate the air in your room, and recommending an air exchange rate of a minimum of 6 per hour is what's recommended by Dr. Zaatari. Please look at that webinar. You'll learn a lot. It's really changed my understanding of this whole concept.
That makes a lot of sense. And especially, if you hear, open a window, it'll be fine, versus the actual method of circulating the air and how different that could be. Yes. So another question come in. Is there a primary action that needs to be taken in case the mixing of agents is suspected? And the question here is then more specifically, mainly at home while waiting transfer of a patient to a hospital. And so I think the question there to get more depth is,
yes,
if in fact it's fixed. Yeah, so please go ahead.
Well, this is kind of a hazmat question. So I'm more comfortable with these questions. So yes, certainly this is a gas that can expose the responders. Luckily for us, the amounts that are usually mixed is small, and therefore, likely to be an instantaneous exposure that is dissipated in the environment and diluted, and therefore a bit safer for our responders. But remember, also our responders were injured in Graniteville when they responded to the scene. And of course, that was a massive release of chlorine gas. So it all depends on the dose here. Responder safety is of paramount importance. If the suspicion of a massive exposure, then certainly wearing a self-contained breathing apparatus is essential here, which our fire department hazmat team will have to enter the scene. If it is a situation where the exposure is low, the good thing about chlorine and chloramine is that they have good warning properties, and therefore, they can irritate the mucous membranes of the eyes and throat before they affect the lower airway. So potentially, somebody can detect the hazard right away and move away from it. This is, again, in your trivial exposures at a home setting. But when we're looking at large amounts, I think I prefer my responders to be well protected with an SCBA respiratory protection, as opposed, or because some of these are gases and require this type of protection.
One more here. This is a broader question based on your just general expertise and experience. But if we were to ask for you the one biggest misconception that you'd like to strike down or have your moment to speak to here about disinfection and sterilization, what's the one that you hear the most, that you think causes the most damage, drives you the most crazy based on your experience?
I feel like the regular people, as well as healthcare professionals, are dealing with a lot of stress at work, and a lot of requirements, just always more requirements. And I think we tend to get tired of these measures. I hope we can remember to wear gloves when we apply these chemicals to disinfect the stethoscope or surface. Sometimes it's just easier to reach into a box of these wipes and just wipe the surface. Remembering not to spray them. I don't like spraying them. I think you just apply them on a rag and then apply them. Thinking about your patient that comes in and that has asthma attack, asking these questions can go a long way. Ventilating if you can, or cleaning before people enter a room, waiting a little bit before you use the room. I think all of these are some of the kind of the pearls of wisdom that I've learned, that I've experienced and observed in my home and my work setting.
Well, Dr. Kazzi, thank you so much. I think that's it for the questions for the day. So I just want to thank all of our attendees today. Please, once again, once you close the Zoom browser here, go ahead and fill out our evaluation. It'll only take a couple of minutes. Please join us on January 18th for our next webinar in this series. And once again, Dr. Kazzi, thank you so much. And everyone have a great day.